Cancer of the ovary, ovarian cancer, is one of the deadliest forms of cancer there is. And one of the deadliest forms of ovarian cancer is called high-grade serous. And researchers at the University of British Columbia in Vancouver have embarked on an enormous program which could reduce the incidence of ovarian cancer by 50%.
The common ovarian cancer, the high-grade serous ovarian cancer, probably isn't ovarian cancer at all in most cases. And the reality is one of the commonest surgeries that's done in women in North America is a hysterectomy. The majority of those hysterectomies are done in the premenopausal age group for benign disease, and the ovaries are left in the patient. And when the ovaries are left in the patient, traditionally we've left the fimbriated end, the part of the tube that embraces the ovary, the part of the tube where these cancers occur, in the patient.
And that's the core of your prevention campaign.
By simply changing the way we do hysterectomy, not asking more women to have hysterectomies, but if you're having a hysterectomy, take the tube out at the same time, there's pretty good evidence that we will be able to prevent a large number of these cancers. In our British Columbia ovarian cancer database, we know that 20% of the women who developed high-grade serous cancers had had a hysterectomy in the past. That means for those 20% of women, we would have had an opportunity to prevent that cancer by taking the tube out at the time of hysterectomy.
Is it very involved to take that extra bit of operation, the fimbriated tube that cups the ovary?
No, it's actually a very simple procedure. The fallopian tubes, actually, I guess they really do belong to the uterus rather than to the ovary, if you think of it, because they're attached to the uterus. And it's really just a matter of, moving one clamp at the time of the hysterectomy.
And of course, there's a second procedure where you can take the fallopian tubes.
Yeah, so another procedure that's very commonly done in North America is the tubal ligation. When women feel that they know or do not wish to have any further children, certainly 20 to 30% in North America of North American women will have a tubal ligation. In the past, we used to recommend destroying as little of the tube as possible in case the woman changed her mind and she wanted to have it reversed. But now, if a woman or a family changes their mind and wishes to have more children, it's much more common that they would have assisted reproductive technologies like in vitro fertilization. And because of that, I think this is another opportunity to remove the fimbriated end of the tube instead of tubal ligation. Again, another potential to prevent another 10 to 20% of these cancers. Then there's a third opportunity, which is also part of our program. We know that the high-grade serous cancers are strongly associated with germline mutations in BRCA.
And these are the breast cancer genes?
Well, the breast ovarian cancer,
Yes.
We don't want to give it just to breast. So BRCA1 and BRCA2, about over 20% of the women in our province who develop high-grade serous cancers will have a germline mutation for BRCA1 or BRCA2. If we test all of those women who develop this cancer, then we can get very important information for their family members. Because if they test positive, then we can offer genetic testing to their sisters, their daughters, their mothers, and we can identify women who are at a very real risk from carrying a germline mutation and offer prophylactic surgery.
Now, when women are discovered to have these breast cancer genes, they're offered bilateral mastectomy to prevent the breast cancer, and also fairly radical procedures removing the tubes and the ovaries. Does this research suggest that in fact they could have a lesser procedure and leave the ovaries in place?
You know, it's an excellent question. We've struggled with that. I will tell you that a lot of patients are sort of voting with their feet because they're aware of this literature as well. The tremendous benefit of prophylactic surgery is based on doing bilateral salpingo oophorectomies. It's very difficult in the absence, exactly. It's very difficult in the absence of good data on salpingectomy alone to take this very high-risk group and say, we're just going to take out your tubes. I think that my personal feeling is that may well be the case in the future. I don't know if it's ready for prime time right now. I do know that women who do carry BRCA, particularly if they're very young, may opt to have the tubes out and then consider having the ovaries out at a later date. I suspect this is an area where we're going to, the knowledge is developing, and we're going to get a lot more information that's going to answer that question.
And of course, this is low-hanging fruit.
Absolutely.
And no
Absolutely.
cost.
Yeah, you know, I mean, it adds no time to the time for hysterectomy. It is a very simple modification, and it should have no cost to the healthcare system, this modification.
Are there any harms from this procedure? It's been said, for example, that by taking the tubes, you could actually get premature ovarian failure. In other words, the ovaries go to menopause faster.
I mean, I think I would be fibbing to say that there's been no pushback, and the two real pushbacks we've had is just the question you ask, is are we harming the ovaries by taking out the tube? And there is no evidence of any increased ovarian failure or premature menopause, or and if you actually look at the anatomy, the blood supply to the ovary does not come through the fallopian tubes, so it's not really even biologically plausible. The other pushback that we've got is, you know, instead it was on the tubal ligation side, that it's going to take longer, it's a more complicated operation, et cetera. And, you know, we kind of let that one go because we thought if we can win the hysterectomy battle, we'll save the tubal ligation for later. But in reality, we've been very pleased with the anecdotal feedback we've got from people because, you know, many of these people are very skilled laparoscopic surgeons, and for them to take out the fimbriated end of the fallopian tube is a quick, efficient, and low morbidity procedure. So overall, we would conservatively estimate that we could decrease the incidence of this cancer by 50%. And decreasing the incidence is way more powerful than a better treatment or better screening.